Good evening, everyone. Welcome to the webinar series aiming final MBBS exam this time. Today we are going to discuss about management of chronic pancreatitis. It will be discussed by Dr. Buddhika Dassanayake. He is the senior lecturer in University of Peradeniya, Faculty of Medicine. And he is a general surgeon as well as pancreatic biliary surgeon. He graduated from University of Peradeniya. After MD Colombo, he got his overseas training from Birmingham Hepatobiliary Center. I think he is the ideal person to discuss this topic with you. I welcome Dr. Buddhika Dassanayake to start to this webinar regarding chronic pancreatitis. Buddhika Dassanayake.
Thank you very much, Dr. Dixon. So I think I will share my entire screen, if that's all right with you, and that way we'll probably be able to move through this faster. Please let me know if the presentation is now visible on full screen. Yes?
Yes, we can see it.
Great, thank you. So the way we will go is, if you have any questions at any time, just drop a message in the chat and we will pause to discuss that. So keep typing your questions, or if you feel as if you want to ask, you can switch on your mic and ask immediately. I'm not fluent in Tamil, unfortunately, but in Sinhalese or English, I can explain. So feel free to talk in either Sinhalese or English if you have questions. Next, at some points, I will want your answers to keep the discussion going. And at those points, there will be a blank slide with a question mark or something on it. And I'll ask you to type in. And once your responses are all there and we come to some kind of consensus, we'll move on from that point. So for that reason, the faster you do respond and the more you talk, the faster we will be able to get through the slides as well. So partly the pressure is also on you to respond as much as you can to keep this discussion interactive. Okay. So we'll go through chronic pancreatitis in the next 45 minutes to 50 minutes. What do I mean as chronic pancreatitis? So does anyone know? In your words, what do you think is chronic pancreatitis? So just drop any answers if you can. You can type them in the chat, or you can just unmute and reply to me. Anyone? Yes? What do you think is meant by chronic pancreatitis?
When there's a long-standing inflammation to the pancreas?
Okay, yeah. Long-standing inflammation.
So long-standing chronic inflammation which results in the destruction of pancreatic parenchymal cells where they are replaced by fibrous tissue.
All right, good, yes. So long-standing inflammation causing destruction and the pancreatic tissue getting replaced by fibrous tissue. And I've shared the screen so you can probably see responses that are coming up in messages as well. There's chronic inflammation of pancreas causing progressive parenchymal damage. Good. Irreversible fibrotic change due to chronic inflammation, resulting in endocrine and exocrine insufficiency. Good. Anyone else? So you kind of know what's going on. That's very good. So part of this comes from our understanding of the difference between acute inflammation and chronic inflammation. Good. Again, the word permanent damage has come with the third response here. Long-term inflammation that leads to permanent damage to its structure and function. That's also a nice definition. Okay. So all the definitions are heading in the right way. So that's very good, right? The key points to remember is that acute inflammation is usually a process where tissues are injured, but there is a chance of regeneration. But in chronic inflammation, there is always associated fibrosis and repair, right? Repair is different from regeneration. Repair means that the structure is permanently changed. So in some organs, we see this. For example, there is acute liver failure, which you can get in paracetamol poisoning or some drugs like phosphorus, hepatitis, things like that, right? And if you support the liver for a time, everything recovers. But sometimes different kinds of liver damage leads to chronic liver cell disease and cirrhosis. And the two entities are completely different because cirrhosis is not reversible. There is acute renal injury and there is chronic renal injury. Acute renal injury is reversible. Chronic kidney disease is not. So in the same way, this word that most of you are coming up with, irreversible, right, is a very important word. Good. And you've mentioned the word fibrosis as well. One of you mentioned the word pancreatic atrophy, that the pancreas shrinks. And another important thing is this word that two people have mentioned, permanent damage to the structure and the function. Very good. So we have a clear idea of what we are dealing with. If we go to the definition that the books give, well, this is kind of a very simple definition that defines all this. So now, understanding what we are dealing with and understanding definitions comes from this kind of discussion. So this is the definition. It's an irreversible fibro-inflammatory disorder of the pancreas. Now let's go back to our responses, right? A couple of responses talk about exocrine and endocrine insufficiency. Now, why is that not included in this definition? We know that that's an important thing. Why is that not included in the definition? And why is there no mention of permanent damage to the structure and the function as well? It says it's an irreversible fibroinflammatory disorder, but why doesn't this exocrine and endocrine deficiency, which we have very correctly pointed out, why isn't it there in this definition? Anyone? It's a very simple answer. Let's see, there's one response coming in. The word chronic has it all. Well, yes, those are complications. Good. That's another way of thinking about it. Occurs in late stage? Yeah, good. That is probably more important. Yeah, good. Still functions can be intact. Depends on the stage we find out. Good. So you're getting the idea. Yeah. So chronic pancreatitis is a progressive thing, right? And in the late stages only, you will find the exocrine and endocrine failure occurring, right? The beta cells and the secretory cells that secrete the enzymes will be working in the early stages, although the patient has chronic pancreatitis. Okay? And so that's why it's defined just as an irreversible fibroinflammatory disorder. Okay? So good. So that's the definition. It's not a very difficult definition, and it's one that will be useful not only to understand what's in the definition, but you need to understand what's not in the definition and the reasons for that. Right. So what causes chronic pancreatitis? That's the next question that we need to answer. before that, the question is, what causes acute pancreatitis? Do you have a mnemonic for that, anyone? Acute pancreatitis?
Get smashed.
Get smashed.
Yeah. Yeah, there's a mnemonic called, well, it's I get smashed, isn't it? Yeah. So I get smashed, where the I stands for a few things as well. For example, there's one I that is idiopathic. There's another I that is inborn. There's another I that is infantile, right? And then you have gallstones, ethanol, and what is T? Trauma. And then you have a list of other things. So idiopathic, inborn, infantile are all in the I. They are different from each other. Inborn is usually metabolic issues, right? For example, problems with various enzymes that stop pancreatic enzymes from getting activated, right? So those things, cystic fibrosis, those metabolic problems cause inborn pancreatitis. Infantile is usually due to structural problems in the pancreas, not metabolic problems in the pancreas. There can be developmental problems during embryogenesis where there is pancreas divisum, things like that, which you probably heard about. I hope everyone knows about what pancreas divisum and annular pancreas are. So those are infantile causes. Then G, E, and T, gallstones, ethanol, and trauma are in order. The commonest cause in females, commonest cause in males, and T is, apart from the eyes, it is the commonest cause in children, T. So that is how it goes. Now, are these all relevant to acute pancreatitis as well, to chronic pancreatitis as well? That's the question. Is it the same things that cause acute pancreatitis, chronic pancreatitis also? Same list or different? What do you think? Anyone?
Different, sir?
Are all of them different? What do you think?
Majority are similar to the acute pancreatitis cause.
Well, yeah, that's the thing. Majority of them are due to acute pancreatitis. The weird thing is, actually, no, there is not much of an overlap. For example, gallstones are probably the commonest cause of acute pancreatitis that we see. But we don't ever get that causing chronic pancreatitis, right? Alcohol, yes, definitely it can cause acute as well as chronic pancreatitis. Okay? Then what else? Let's go to your responses. Some are different. Yeah. So yeah. There are some things like scorpion bites that cause acute pancreatitis that are never going to cause chronic pancreatitis. You don't get bitten by scorpions over and over again, no? Things like that. Then there are some other things like smoking, right, which never cause acute pancreatitis, but they do cause chronic pancreatitis. Now, you have said inborn and idiopathic are common. Yes, to both. So some of the things in acute pancreatitis, yes. So chronic pancreatitis, again, we have to look for different details. For example, this is one mnemonic for chronic pancreatitis, right? What we call the TIGA-O mnemonic. So just like your mnemonic for acute pancreatitis, I get smashed, you can use this TIGA-O mnemonic for chronic pancreatitis if you like, right? Then we have various genetic mutations. Now, earlier we had an entity which people described as tropical chronic calcific pancreatitis, right? You will see this over here, right? This thing over here, which says tropical. Now, remember, you can only call someone tropical idiopathic pancreatitis if you have excluded all these things, these genetic mutations, these autoimmune syndromes, right? Things like that. So in Sri Lanka, what do you think? Lots of people are labeled as having idiopathic tropical chronic pancreatitis. But actually, they might be genetic mutations, they might be autoimmune, things like that, because we don't have the tests to pick up whether these people have PRSS, CFTR, that is the cystic fibrosis gene, SPINK, etc. Okay? But all these are causes of chronic pancreatitis. And if you look at them, they are very different from each other, right? Some of them you can understand. For example, at the top, alcohol, tobacco, smoking, long-term hypercalcemia, some drugs, toxins. And you can probably understand some things like the pancreas divisum being there for a long time, obstruction at the sphincter of Oddi, and things like that, or post-traumatic scars in the pancreas, right? Now, this is an interesting thing. If you have recurrent severe acute pancreatitis, right, that can cause chronic pancreatitis by itself. So, let's say that someone has gallstone pancreatitis, acute pancreatitis due to gallstones, and you don't treat it, and they have several episodes that can lead to irreversible fibrosis of the pancreas also. But one episode of gallstone pancreatitis or just having gallstones is not taken as a cause of chronic pancreatitis. So this is one way of looking at the etiologies. The reason I am putting this slide here is that you will probably have to go through at least a few of these, however you can, in your history when you are faced with a patient with chronic pancreatitis, right? You have to look for the cause. This is another mnemonic called Mannheim. Alcohol, nicotine, nutritional, hereditary, then immunological, things like that. So that's another mnemonic. These are all available online. So just like I get smashed, you can read more about them. Right? Now remember, you need to know I get smashed probably by heart, because acute pancreatitis is a surgical emergency. You have to deal with those patients the way you deal with an acute abdominal pain. And looking for etiological causes is an important thing. Chronic pancreatitis is different, right? You have plenty of time. So I don't think anyone would expect you to know all these causes by heart as an HO, right? It's not going to be something that fails you at the exam. Yes, you might get a distinction point if you have some of these in an MCQ, but this is not essential knowledge, right? You can always read up about them because now you know that there is a mnemonic called Tigaro, there is another mnemonic called Mannheim. I have a patient with chronic pancreatitis. I can go and read. Okay, so you have to, this is just a general rule as well. When you are studying, you have to be able to work out what you need to essentially know and what you are comfortable with going to a book and reading, or going online and searching for. Then you can always search for. Next question. How will we diagnose chronic pancreatitis? Now, when you answer this, again, I need some responses from the group. I would want you to think about how we define chronic pancreatitis when we talk about how to answer this. Yes, anyone? You can type in your responses. Or you can talk. Clinically, yes. Good. CT scan. Good. CT. Serum amylase, blood glucose, liver functions. MR, magnetic resonance, CT scan. Histology is the gold standard. Imaging. Good. Responses are coming. Go on. Keep going. Good. Does one always need to have acute pancreatitis for it to progress to chronic pancreatitis? Abdominal pain. Ideally, histology if possible. Abdominal X-ray. Okay, good. So we have lots of responses. Now again, I would like for you to discuss these one by one. We'll go from bottom to top. CT scan, says Dimitri. What do people say? Yes, no, good, bad? Give your responses. What do you say about CT scan? Anyone? Yeah. So now let's just draw a pancreas here. Right? I'll try my best not to make it too ugly. Let's say that this is the pancreas. And this is the pancreas duct. Now remember, the duct has branch ducts, okay? Unlike the bile duct, there are always branch ducts as well. Right. So this is the so you have the parenchyma and you have the duct system. Now, when you talk about this word, which someone has mentioned here, architectural rearrangement, yeah. So there are three things that we look in image, right? The three things that we look for: duct abnormalities. What will happen to the parenchyma? Yeah, parenchyma will atrophy, right? And there will be calcifications. Now, the CT scan can give us a good idea about all of this. It can show us that the parenchyma that was previously this large has now shrunken to, sorry, wrong color. It will show us that the parenchyma that was previously this large has now shrunken to this size. So the parenchyma has atrophied now, right? It will show us that the duct that was previously like this, now in certain places that the duct is, sorry, wrong color again. It will show us that the duct is dilated in some places, right? Like that, the duct is massively dilated in some places, right? So you have very dilated duct and almost no parenchyma. And in some places, there will be strictured narrowings in the duct also, where the duct is completely blocked off. And then there will be dilatations. And everywhere, inside the parenchyma and In other places, you will see calculus, right? Everywhere there you will see a dilate pictures in atrophic paralysis, lots of calculus. So all these changes you can see. So the CT scan will show you all that. So it's quite good, right? So the CT is good. What about pancreatic edema? Now, pancreatic edema is a feature of something acute going on. In chronic inflammation, you might not have any pancreatic edema at all. So that's not necessary. That might show us that there is acute or chronic pancreatitis going on, but that's not necessary to diagnose chronic pancreatitis. Now, the CT shows you all these three things, right? What about the MRCP? Does the MRCP show you all these three things? Yes or no? You can talk also. It's tedious to keep typing all the time, no? What does the MRCP show you? So there you must know the difference between MRCP and MRI. MRCP is magnetic resonance cholangiopancreaticography. You are just looking at only the duct, cholangiopancreatic. Yeah, so it doesn't show us much about the parenchyma. You can't see the calcification, right? You can't see much about the parenchymal atrophy, but it's really good at picking up the duct. Actually, MRCP is more sensitive at looking at ductal abnormalities than CT. So in early stages, it might pick up ductal abnormalities before the CT does. So CT is pretty good for calcifications and for parenchyma. MRI is very good for the duct. CT is pretty okay for the duct. Can't we do X-ray to see calcification? Absolutely, yes. You can do an X-ray as well. And if you see calcifications there, definitely. Okay. So let's go up again. What were the other answers that you had given? Can you guys see your responses as well in the chat? Yes or no?
Yes, sir.
You can see, right?
Yes, sir. Yeah.
Okay. Good. So what about this endoscopic ultrasound? Good, bad? Endoscopic ultrasound is also good. Is it better than CT, better than MRI, or worse? What do you think? Not much sensitive. Good, better visualization of duct and parenchyma. Invasive. Well, it is invasive in a way. It's an endoscopy. Yeah. Endoscopy is actually more sensitive than the CT and the MRCP in looking for parenchyma calcifications and duct changes. So it's actually even more sensitive. Right. Next question. So let's go to abdominal X-ray. We've talked about it. Yes. If you see calcifications, yes. Ideally, histology if possible. Next, clinically with exocrine failure, malabsorption, endocrine failure, diabetes, abdominal pain. Yes. So what do you think about these two? We'll go with the top one first, clinically. What do you think about that? Can take biopsy. What is more sensitive? Clinical changes? Yes, no? Why no? Why isn't clinical good? Recurrent abdominal pain. Yeah, so that's the thing. Now, let me ask you this. You know the typical pain in chronic pancreatitis, no? Upper abdominal severe pain, and it's persistent, dull, worsening with meals, relieved by bending forward. They are wasted, they are lying in bed all the time. Does everyone with chronic pancreatitis have this? Yes or no? Does every patient with chronic pancreatitis have pain? That's the thing. Lots of patients don't, right? Many patients do, but you will get a significant number of patients, especially these days when we do imaging for other things, we pick up chronic pancreatitis incidentally. Patients whom we only thought were diabetic, right, or a bit malnourished, turn out to have chronic pancreatitis, but they've never had pain. So, that's a very important thing to remember. So, clinically, you can't always diagnose it. Right. So if you want to go for the most accurate diagnosis, so far, clinical is probably the least accurate. Abdominal x-rays may be next. Next, we have CT and MRCP, right? US is even more sensitive. Most sensitive would be what? I think someone had mentioned it also. Histology, right? The most sensitive is histology. And that is because of this definition of, so it's not a fair game, right? They have created a definition of chronic pancreatitis that says irreversible fibroinflammatory disorder, which means that so many people with fibrosis and inflammation might not have any duct abnormalities, any calcifications, any fibrosis, any duct changes or parenchymal changes that even EUS can see. But cellular level, those changes might be there. So that is why the definition is also the cellular definition, that it is an irreversible fibroinflammatory disorder. And step by step on top of that, they get the parenchymal changes, the duct changes, the calcifications, and slowly they become first diagnosable with US, next with CT and MRCP, next with an abdominal X-ray, and then even clinically. And somewhere along that line, they develop exocrine failure and endocrine failure, so we can use those also. So this definition comes back to haunt us, because when we talk about how to diagnose chronic pancreatitis, then we have to understand again that the gold standard is histology. But when it comes to your patient, okay, now I'm going to say the exact opposite of what I said all this far. So you've got to understand carefully what I mean. The gold standard is histology. But do you need to do histology in everyone? If the patient has clinical pain, exocrine failure, endocrine failure, we just go with our basic imaging. That's enough. If our basic imaging, which is ultrasound, X-ray, and CT, don't show anything, we might go for MRCP or EUS. And if that doesn't show anything only, we are going to go for histology, which is usually not done. And remember, histology is also done with endoscopic ultrasound. Does that mean always that clinically evident patient is always late stage? Absolutely. Yes. That's the problem. Okay. So there is another thing in hepatobiliary disease that is very like the pancreas in that way, right? And that is the liver. When patients present with cirrhosis, they have had cirrhosis for a long time, because we can, the liver has a huge physiological reserve. In someone with a healthy liver, we sometimes remove 2/3 of the liver. We resect it when there are liver tumors and all that, and they are fine. They don't go into liver failure. right? That is because 20-30% of liver parenchyma is enough to sustain normal functions in a normal liver. What that means is until 80% of the liver gets damaged, people don't present with features of cirrhosis. Same way, you need to have extensive damage to the pancreas for its reserve to be lost. Now we resect half of the pancreas when we do a distal pancreatectomy or a Whipple operation. The patient doesn't develop diabetes or exocrine failure, right? So that's pancreas also has reserve. Can we visualize the pancreas adequately with abdominal ultrasound scan? No, right? That is not a good test, because anytime the pancreas gets angry, that's when you want to visualize the pancreas. No, the pancreas is hiding behind the stomach, right? The stomach is, yeah. So if the abdominal wall is like this, the stomach is over here and the pancreas is behind it. And anytime that the pancreas gets irritated or inflamed, acute or chronic pancreatitis, the stomach will distend. And so the poor radiologist, right, has to scan across this gas distended stomach to visualize the pancreas. And it becomes harder to visualize there. So abdominal ultrasound isn't. With endoscopic ultrasound, the probe is over here and it's touching the posterior wall of the stomach and looking at the pancreas directly. So it's a really good way of visualizing the pancreas without any of those issues. What about pancreatic secreting stimulation test? Good question. So there is a thing called the secreting stimulation test, where we give the patient a certain amount of secretin, which causes the pancreas to stimulate. We put an endoscope, a special kind of endoscope called an ERCP scope, and we cannulate the pancreatic duct with it. And we stimulate the pancreas with secretin, and we take the secreted enzymes out and we check the enzyme concentrations. That is a really accurate way of assessing exocrine dysfunction. It will tell you nothing about endocrine dysfunction. It will tell you nothing about the cellular things. So it's a gold standard for finding exocrine dysfunction, right? But it causes so many complications that it's only done in research settings. So we don't do it at all, right? Okay. Place for fecal elastase. Again, a good question, right? So we are talking about what secretes elastase? The pancreas secretes elastase. So the stool of a healthy person should have a certain amount of elastase in it. If the amount of elastase in the stool is going down, what does that mean? Anyone? That is a if the amount of elastase in stools is going down, yeah, exocrine function, it's called a indirect measure of exocrine function, right? Putting a cannula into the duodenum and measuring the amount of enzymes that are coming out is a direct measure of exocrine function. Stool exocrine, pancreas, yeah, and fecal fat is again another one. So all that, this should be fecal fat, FECAL. Fecal fat is also an indirect way of checking exocrine function. What would the fat level in the feces be if you have pancreatic dysfunction? Now we know that elastase levels in the stool will be low if you have pancreatic dysfunction. Yeah, fat will be high. You can actually look at it under the microscope and you can see fat globules in the stools. Okay, so these are all ways of assessing exocrine dysfunction, right? This is a good question. What happens to serum amylase and lipase? In fact, one person had said diagnosis with amylase and lipase. That's a really important thing to remember, right? Now, acute pancreatitis is diagnosed when you have 2 out of 3 criteria. We are talking about acute pancreatitis, okay? Acute pancreatitis, to diagnose it, you must have clinical evidence, you must have biochemical evidence, which is amylase, lipase, or something like that, and you need to have imaging. If 2 out of these 3 are there, that is acute pancreatitis. Chronic pancreatitis, we've talked about the gold standard of diagnosis and the other diagnostic modalities. There is no 2 out of 3 or something criteria for chronic pancreatitis. Okay? And the important thing to remember is that your amylase levels are going to be normal. Again, a similarity there is in acute liver failure, your AST, ALT levels are going to be very high. But in chronic liver cell disease like cirrhosis, you are going to have normal AST, ALT levels. So just like we can't diagnose chronic liver cell disease with AST, ALT, you can't diagnose or even exclude chronic pancreatitis with serum markers like serum amylase or lipase. They are useless. If clinically suggestive of chronic pancreatitis, what is the initial investigation? I would say initial investigations would be an abdominal X-ray and an abdominal ultrasound. And then you can progress to a CECT. Okay? That's for imaging. Right. So all these are with diagnosis. And this is your abdominal X-ray. And you can see calcifications. The pancreas is roughly at the lower border of L1, which you can see. It crosses the midline from here to here, and you can see a load of calcifications over there. And we'll have a brief look at some CT images. We do both non-contrast CTs as well as contrast CTs. So let's have a look at some non-contrast CT images. Guess what you see in the non-contrast CT? Anyone? Can you see this image? Yes? Can you see the image here?
Yes, sir.
Yeah. Okay. So we are going to move slice by slice in the CT. Remember the previous image, the pancreas is not in one line. You have to go up and down, right? So we'll go over here again. The head of the pancreas is actually lower down. You can see a little bit of the liver over here, little bit of the spleen, and yeah, you can see loads of calcifications. I'm moving up towards the tail of the pancreas, and you can see rows of calcifications up to the tail. Now the spleen is up here, and you can see up to there calcifications. So that is what a non-contrast CT would look like. If we take a contrast CT, right, you would probably see the same thing, but other structures like the liver will be much more visible. Hope you can see. That is the head of the pancreas. And we are slowly moving upwards along the body. And we are moving towards the tail. And this black thing that you see here is the dilated duct of the pancreas, right? Again, that's not in a straight line. So as you move in one direction, you will see the duct going down, and then you will see the duct, moving up there, and that is the dilated duct you see in the middle. As you can see, some calculi are inside the duct, some calculi are outside the duct, right? And you have a load of calculi like that. So that is what you're going to see. So you can see the parenchyma, which is atrophic, right? This pancreas is almost all duct, right? The biggest thing that you can see here is the duct. There's very little parenchyma on the two sides. So that's what the pancreas looks like. Okay. So we'll get back to our presentation now. If clinically suggest, yeah. So now there are so many algorithms that talk about what to do when you have a clinical suspicion of chronic pancreatitis. I hope you can see this. Now, this is for overseas and they don't go with X-rays and ultrasounds, but here we usually do an abdominal X-ray and an ultrasound scan, and only then do we go for cross-sectional imaging. And we first go for CT. If not that, we go for MRI. If that's not consistent, we go for endoscopic ultrasound. Secretin enhanced MRCP is a different thing. That's not the secretin test we talked about earlier. But as you can see, finally, the gold standard is pancreatic histology. So we don't ever go this far along this road. We usually stop at this point, right? We don't go beyond this point in diagnosing. Right. Now, we are going to take about 5 minutes to brainstorm this patient. This is a 50-year-old bhikkhu from Anuradhapura. He has been diabetic for 11 years. And now he says that there is real worsening of an upper abdominal pain which he has had for a long time. He has been treating this as gastritis in the past. He has bloating and loose stools, and he says there is subjective loss of weight, loss of appetite. What do you want to look for in the history and examination in this patient? Just type the things that you want to look for. Yeah. CCT, two questions that I'm answering while I'm doing that. CCT preferable over NCCT? Yes. Always CCT is preferable because NCCT won't tell you about the pancreatic parenchyma. So you don't know where the duct and the parenchyma are in non-contrast. Only in contrast CT, you can see the parenchyma properly. Are tumors causes of acute pancreatitis? Yes. We are not usually talking about acute pancreatitis here. But yes, tumors are a cause. It's not in the eye get smashed mnemonic, but tumors can cause it if they block the duct. Right. So what concerns do you have? What do you want to find answers to? Okay. Obstructive jaundice features, smoking. What else? What are the other concerns you have? What are the things that you want to look for in the history and the examination? We'll go back to the history. What information do you want to gather here? Let's see your answers. Duration of abdominal pain, associated symptoms, previous episodes, what was done. Melina. Why Melina? What's the reason? Previous acute attacks, pale stools, epigastric pain, acute relapses, any features of autoimmune illness, steatoria. Response to treatment of gastritis, good. It might actually be gastritis, no? Character, loose stools. Stool is hard to flush flow, so steatoria. Okay. Ayurvedic medications, okay. How well controlled is diabetes? Any fluctuations, diabetic complications, risk factors? Should exclude gastric carcinoma? Yes, that's important. Rupture of hemorrhagic cyst. Okay. Early satiety. History of smoking. Exclude cancer. Malignant change. History of alcohol. But medications. Episodes of icterus. Right. Okay, good. So lots of answers coming in. Right. So I'll move past the investigations. This is probably the most important slide in the whole presentation. And it is kind of a summary of the various areas that you were talking about in this chat. Okay. So all of you had talked about various aspects. And what I want to just give now is a big picture summary of all the things that you just said. And this is the list. So some of you wanted to find the etiology. Some of you wanted to know about the pain. Some of you wanted to know about exocrine failure. Some of you wanted to know more about the endocrine failure. Some of you wanted to know whether there were benign local complications like obstructive jaundice, hemorrhage into cysts and things developing. And some of you wanted to know about malignancy. Great. So between you, you have come up with all the concerns. And this slide, like I said, this is the most important slide here. These are the questions we need to find answers to anytime that we have someone with chronic pancreatitis. So part of our job is using the knowledge you learned earlier to diagnose chronic pancreatitis. And we've learned a little bit about what you need to do to search for the etiology, right? Then we have to find answers to the rest of these questions. How bad is the pain? What do we do to manage the pain? Exocrine failure, endocrine failure, and certain benign local complications like pseudocysts, calcifications blocking the head of the pancreas, which can even cause obstructive jaundice, hemorrhage, things like that. And yes, there is a risk of malignancy. So you have to hone your clinical skills so that you can find answers to these 6 questions. And if you can answer these 6 questions, you can manage a patient with chronic pancreatitis. Okay, so that's why I said this slide, if you're forgetting anything else, remember that these are the 6 questions you have to find answers to when you are confronted with a patient with chronic pancreatitis. So we have answered a few of them. We know about the etiological factors. What I'm going to talk about next is a little bit about managing the pain. Now, we use the WHO step up ladder for chronic pain when managing patients with chronic pancreatitis, right? We go with non-opioids. We go with weak opioids like codeine, tramadol, and we might have to step up to strong opioids. But when we do this, we must first know how bad the pain is. And that is a really important question you have to answer. So, whenever you take a patient with chronic pancreatitis as a subject and you take a history, just finding out whether there is pain or not is not enough. You have to be able to introduce some kind of tool to work out how bad the pain is. What is the usual tool we use in assessing degree of pain? Yeah, the visual analog scale. You must be able to introduce the patient to the visual analog scale. And you must ask them so many things. How bad is the pain now? What's the worst pain you have had with this over the past month? And you have to know, remember, not only how bad is the pain, but the quality of life, right? Are you missing days of work? How many days of work are you missing? These people are sometimes breadwinners. They are sometimes school children who are missing days of school. So your social history in pain is really important. What it's affecting, it might be affecting their job, it might be affecting their school performance, it might be making them depressed, it might make them substance abusers. All these things you have to go into in real detail, not just work out what kind of analgesics to give them, right? So you need to know how to assess, right? Then there are some recommended drug classes that we use. We talked about them now. We have the opioids, right? But we usually start with paracetamol. Should we give them NSAIDs like diclofenac sodium? What do you think? Yeah, because we have to give this long term, right? It's not an acute pain. Diclofenac, NSAIDs are good for acute pains, but this is something that goes on for a long time. So yes, we have to give paracetamol, we give opioids, and also for neuropathic pain, we can give things that inhibit GABA receptors and things like that. So we might have to give some neurolytic drugs also, like gabapentin, pregabalin. These might also help. Right. Uh, there are some theories as to whether antioxidants help, enzyme supplements, because sometimes the pain these patients have is because they can't digest food properly. So sometimes if you give them pancreatic enzymes, then it helps, right? So we won't talk about the uh, um, complex things there, but remember there are lots of different kinds of pain management protocols that are there, but it starts with assessment. Your job mostly is to assess the pain. Now, this is probably the second most important thing I'm going to talk about today. Unfortunately, all the important things we are talking about are at the end, right? Too bad for the 17 people who have left in the middle. We started at 280. We're down to 263 now. So, chronic pancreatitis causes pain due to three reasons, right? First reason is due to ongoing inflammation. Sometimes there are big inflammatory masses around the pancreas when that's there. The second reason is that the duct gets blocked and it stretches the pancreas because of calcifications in the duct or fibrosis in the duct. We call that ductal hypertension. And sometimes ongoing damage there affects the retroperitoneal nerves, and then you can get a neuropathic pain. So ongoing inflammation, ductal hypertension, and neuropathic pain, all those three can cause it. So sometimes if this is the normal pancreas that I'm drawing, sometimes you have ongoing inflammation, right? Which means that, okay, we'll draw three pancreases and then you'll be able to get the idea. So these are all, okay, I've drawn three pancreases. This is what the normal duct looks like, right? With a couple of little branches here and here. If you have ductal hypertension, right, the duct will be dilated, massively dilated duct, right, like that. And there will be a fibrous stricture somewhere there. So it's not going beyond that point. And here, there might be a calcification or something blocking the duct here. So stricture here, calcification here, the duct is dilated. Sometimes you don't have ductal hypertension, right? But you have a big inflammatory mass in the pancreas because there's ongoing inflammation, right? So some pancreases will have no ductal hypertension, no ongoing inflammation. They will look like the one at the top here, but still there will be pain. So what will be the cause of pain in that patient? Neuropathic pain. Yeah, fine. So what about the second guy? What would the pain be caused by in the second guy?
Ductal hypertension.
Yeah, this is where it becomes a trick question. So, number one, neuropathy, clear. Number two, ductal hypertension. Number three, ongoing inflammation.
Ongoing
Right.
inflammation.
That would answer. This is, yeah. But number two, that pain also still could be neuropathic. Number three, also the pain. So number one, we definitely know it's neuropathic pain. Two could be due to ductal hypertension, could be new. Three could be due to the ongoing inflammation, could be even neuropathic. Right? Now, how do we find the answer to this? How do we work out whether it's due to ductal hypertension or inflammation or whatever? Yeah, exactly. Can't all three be due to neuropathic pain? Can be. How do you find the answer to this? So that's the other function of our imaging, our CT. CT will show the duct, CT will show parenchyma. So you can get an answer to whether there is inflammation, duct dilatation, everything from the CT scan. And once you have the CT scan, this is your kind of shortcut to working out whether what to do. Now, in some patients, the pancreas is inflamed, right? Yes, right? But the duct is not dilated down over here. There, you can resect the pancreatic head with or without the duodenum. If you do it with the duodenum, it's called a pancreatic duodenectomy or a Whipple operation. Without, it's called a Beager operation. In some people, they are like number two here. Involvement of the head is not there. Sorry, involvement of the head is not there, but the duct is dilated. There, we anastomose the dilated duct to a loop of intestine. I'll show you the pictures later, and that will reduce the pressure. In some people, right, the duct is dilated and the head of the pancreas is inflamed. Both are there. So it's a combination of 2 and 3. Yes to both answers. There, we combine these two operations. We resect the head and we anastomose the bowel loop to the body. I'll show you pictures later. But in some people, the duct is not dilated and there is no inflammation in the head. In those cases, we can go with neurolytic management. So we go with medical management. We can divide the splanchnics in the chest, or like someone said, this is also where the celiac plexus block comes in. Okay. So all these are options that you have here. So this table kinds of tell you which method to use in which case. Right? Can early stage of pancreatic carcinoma get similar presentation? Yes, absolutely. But in early stages, we don't usually get pain. Remember, in pancreatic carcinoma, you get pain when the retroperitoneum gets inflamed. So pain is usually a late cause. Right. So we'll go on to a couple of pictures of what I'm talking about here. Right. We'll try and erase all the muck. Right. So what you can see here, we'll see them one by one going at this corner. In this bottom corner, this is where the pancreatic duct is dilated, but there has been no inflamed mass anywhere. There, what we do is we cut the pancreatic duct open and we anastomose a bowel loop to the side. That's called a Pustow procedure, or the easiest way is calling it a lateral pancreatojejunostomy. That is the Pustow. Right? Sometimes the head of the pancreas is inflamed, right? And so we take out the whole head. That is what has been done in this first picture, where a Whipple operation has been done. But it's a very nuisance operation, because if you remove the head of the pancreas with the duodenum, the bile duct has to start to bring up our the bile duct. Stomach has nowhere to go, because duodenum is gone. You have to anastomose the stomach down there. Lots of problems. So the operation is a simpler one, where you don't remove the duodenum, you just remove a lot of the head and anastomose a bowel loop over there. So the bile duct and all the stomach and all that are intact. Sometimes you can combine the big operation and the Frey operation together, the Whipple and the, sorry, sometimes you can combine together if the head is inflamed, as well as if there is a dilated duct, and that is how you get this Frey operation. You remove as much as possible from the head, and then you cut the duct also open. Okay, and that's a Frey operation. So there are various kinds of operations. Let's see. Even if the pain isn't improved with Frey procedure, can we go for celiac plexus block? Absolutely. What does it mean if the pain isn't improved by the Frey operation? That means although there was an inflamed mass and a dilated duct, the pain was neuropathic. And the problem is, we don't know until we remove the mass whether the pain is neuropathic or not. That's the problem. Now, what if the duct is dilated, okay, and there is no inflamed mass, but the duct is dilated? Let's talk about that second situation, where there is a pancreas like this, right? There are no inflammatory masses in this, but the duct is massively dilated like that. Right. Now, what could the pain be due to?
Ductal hypertension.
Talk.
Neuropathic or ductal hypertension.
Could be due to ductal, could be neuropathy. And now we are going to answer that exact question that you have asked over here. If it's due to duct obstruction, can't we release that obstruction without major surgery? Absolutely. And that is where our ERCP comes in. Okay. So there is a way of releasing that obstruction without this. This is a case that we did recently here. As you can see, with the endoscope, you can go in the duodenum and you can cannulate. You can see there's a macellate duct here with ductal hypertension. And we can, through the endoscope, we can, with ERCP, get the a guide wire into this. And here we have passed a stent, just like a ureteric stent. We have passed a stent in, and that will decompress the duct. Now, if this relieves the pain, that means that the pain was due to ductal hypertension. Now you have two options. These stents don't last for long. They last for about 6 months. Then they get blocked, just like ureteric stents. So one option is you can keep changing that stent every 6 months. Or now that we know that the patient has ductal hypertension, definitely as the cause of the pain, we can go for a definitive surgery, right? So ERCP is a very useful tool that we have, sometimes to treat the pain and sometimes to actually diagnose that this pain is due to ductal hypertension. Then we have talked about pain management, right? We've talked about assessment. We've talked about some of the benign local complications. Endocrine failure is another important area if you get a patient in a long case that you have to focus on, because these patients may have, just like this priest, all the macro and microvascular complications of diabetes by the time they come to you. So you need to be able to have a complete history. Your patient might have chronic pancreatitis, but their cause of death might be an MI or a cerebrovascular accident, right? Or their big problem now might be that they have claudication, right? So if the patient has diabetes, that is a whole ball game, and you need to be able to quickly assess micro and macrovascular complications of diabetes in any patient within about 5 minutes, right? Then what else? Regarding exocrine failure, I didn't talk about it. I want you to tell me how we deal with exocrine failure and nutritional management of patients with chronic pancreatitis. Can you answer that now? That's the last bit we are going to talk about before we go to questions. Okay, pancreatin tablets, yes, not tablets, capsules, modify high carbohydrate, low protein and fat. Good. Yeah. So, yeah, good. So you get the basic idea. There are dietary modifications that you can do as well as enzyme replacement. Enzyme replacement is the better one. We do dietary modifications also, but remember, the problem with giving a high carbohydrate and low protein, low fat diet to these patients is what? Anyone? Yeah, exactly. Most of them are diabetic, no? So the managing the exocrine failure is interfered by their endocrine failure. So that's only partially manageable. There are other things called medium chain triglyceride feeds and all that, which are expensive. Medium chain triglycerides don't need to be broken down by pancreatic lipase, so they can be absorbed directly. You can give them MCTs, medium chain triglycerides. But the mainstay is pancreatic enzyme supplementations. You have to give them a lot, right? And there are online tables that you can refer as to how much you can give depending on their etiology, weight, etc. And you have to calculate their dose. We can't just be giving the same dose for everyone. Fortunately, they have started to produce pancreatic enzymes in Sri Lanka, right? And so we can afford to give these patients that. Otherwise, earlier it would cost around 1,000 rupees to have it taken outside, which is why most of these people are malnourished. So you have to give them pancreatic enzymes to take with meals and degree of dietary modification. And is that all? Anything else? How is their nutrition? Yeah, okay, small frequent meals. That's a problem because then they have to take more pancreatin. Anything else? Now remember, yeah, good. We need to work on micronutrients also. Because if you have obstructive jaundice in a patient, you know about obstructive jaundice as a different topic, but you get usually as nutrient deficiencies, vitamin K deficiency, because it's a very acute thing. But when you have pancreatic lipase deficiency going on for months and years, all your fat soluble vitamins are not absorbed. So vitamin A, vitamin D, vitamin E, all that is also not there. So what happens if you have vitamin D deficiency for a long time? Yeah. So you have to give them calcium supplements. You have to do DXA scans on them, right? You have to give them vitamin D supplements. All these things need to be done. You have to check their vitamin levels. From time to time, they need to give mega doses of vitamin A, vitamin D, things like that. They don't usually develop coagulopathy, but these are things that you have to look out for. So it's not just macronutrients. You've got to think about micronutrients also. And whenever you talk about nutrition, you must start with assessment. You must check their body weight, right? You must check their BMI. And every time they come to clinic, the things that we check are these. We check their visual analog pain score over the past month, work out how many days of work they lost. We check their body weight. We check their sugar control, right? When we do all these things every time. So these are things that you have to keep an eye on. Right. So that kind of brings us to the end of the discussion. Isn't ERCP and stenting itself going to cause pancreatitis? That's a good question. It causes acute pancreatitis, but in people who have chronic pancreatitis, no, they don't usually get acute pancreatitis. Yeah. Any other questions?
So with the time the pancreas will atrophy, the this mechanism of pain is that resolved
I didn't quite follow that question. Can you repeat it?
after prolonged time after pancreas is fully atrophied. This mechanism of pain mechanism resolved and patient the pain wise that patient gets better.
So can you type the question? I think there's an audio issue. I can't hear really clearly. How about the successful rate of surgery? That's a good question. The pain comes back. So we do all these surgeries for them, but 5 years later, most of them have neuropathic pain. So they have short-term success rates are very good, but long-term the pain comes back. But people have shown that surgical pain relief is better than with ERCP. Can you develop pain due to all three causes? Yes. Potential long-term complications of enzyme therapy? Absolutely not. Usage of antibiotics in acute pancreatitis? Yes, there are some instances when we use antibiotics in acute pancreatitis. That's not relevant to this discussion. In chronic pancreatitis, usually not. How do you differentiate chronic from acute on chronic? Okay, we'll pause and answer that question first. Now, how do you differentiate? Those are clinical definitions. Now, if this is pain and if this is time, chronic pancreatitis patients always have a little bit of pain. So, their pain baseline is never 0. Their pain will always be somewhere like that. If you have acute on chronic pancreatitis, you have a background of pain, and on top of that pain, you have acute flare-ups. If you have pure acute pancreatitis, you absolutely have no pain, you have an acute flare-up, and then you have no pain at all. So this is chronic pancreatitis, this is acute pancreatitis, and this is acute on chronic pancreatitis. So it's a clinical definition based on pain. But remember, it's not as simple as it sounds, because some patients with chronic pancreatitis never have pain. So you might think it's acute pancreatitis. You might think it's this guy over here. But only when you do a CT scan or something, you'll find, oh gosh, the guy has been having chronic pancreatitis for a long time. So although it's returning to baseline, he's one of those chronic pancreatitis patients without pain. So it's actually an acute on chronic. Okay. So there you have to go with the definition of chronic pancreatitis and the definition of acute. Right. Back to your questions now. Whipples removes the distal stomach. So how do they maintain distal sphincter function? There is no distal sphincter. That's a good question. So food can go back into the stomach and bile can reflect back into the stomach. The pyloric sphincter is not there. With time, when the pancreas gets fully atrophied, people will get better. Unfortunately, not. The neuropathic pain actually worsens with time. Right? Can we go for total pancreatectomy given that pain recurs? Absolutely. Overseas, total pancreatectomies are sometimes done for severe pain. But what is the disadvantage? Complete exocrine loss, complete loss. So in a country where you have lots of options for that, sometimes total pancreatectomy is done. Now, implants can be done. Okay. So you can remove that bad pancreas and then transplants, and that can sort the problem out completely. But we don't have those facilities. In our case, if we do a total pancreatectomy, the exocrine and endocrine dysfunction just becomes much harder to manage. That's the reason. But yes, it can be done. Could diabetic autonomic neuropathy contribute for pain cessation? Not really, because the autonomic neuropathy, it for some strange reason, the sensory neuropathy is peripheral, and the autonomic neuropathy just seems to cause gastroparesis and constipation in diabetics. It doesn't really reduce the pain. That's a good question. I haven't seen it ever happening. Right? We talked about acute relapsing. For the diabetes control, is it better to use insulin over oral hypoglycemics? That's a good question. What do you think? Yes or no? Okay. What about sulfonylurea drugs? Are they going to be useful? So some anti-diabetic drugs work by stimulating the pancreas to produce more insulin. Those are useless here. Right? But some drugs that cause more glycosuria, like empagliflozin and things like that, may have a place. But the mainstay is insulin, because by definition, chronic pancreatitis, it's an insulin-dependent diabetes mellitus. So that's the reason. But some new drugs can be used along with the insulin. Can we say obstructive jaundice is a complication? Yes. If you get inflammation in the head, you can. And if you get a malignancy in the head due to chronic pancreatitis, that can also cause it. Is fecal elastase testing done in Sri? It's available in the private sector, but it's not commonly done. Sometimes we do it, but the only advantage is that you can save some money giving them pancreatic enzymes early. But now the policy is give them enzymes anyway, because that can reduce the burnout of the pancreas. So you don't need to always do it. Can we clinically suspect where the inflammation is going on according to the features of exocrine and no, they are different. Inflammation is a different thing. Exocrine and endocrine failure are different. Dumping syndrome is not related to pancreas or pancreatic surgery, but it's an important complication of gastrectomies that you will need to know about. Is there a place for conservative management? Absolutely. That's why you go with the WHO pain ladder first. We operate or do ERCP only if we get to the third level and it's still not working properly. If the question asks about complications of chronic pancreatitis, can we take complications of acute pancreatitis as an answer in the MCQ? Some complications, yes. But complications of chronic pancreatitis, not all the complications of acute pancreatitis occur. For example, you're not going to get things like DIC, ARDS, and things like that here. You don't get acute kidney injury, acute liver injury, and things like that. But pseudocysts, you might get. Portal vein thrombosis, splenic vein thrombosis, things like that you might get. All right. Do we do screening for pancreatic cancer in patients with chronic pancreatitis? Good question. Not always. Now, this is something that people have debated for a long time. Patients with chronic pancreatitis have a 100-fold increase in risk of pancreatic cancer compared to normal people. The problem is that pancreatic cancer only affects 1 in 10,000 to 1 in 100,000 people, which means you have to be doing annual CTs in 100 patients with chronic pancreatitis every year to pick up one new cancer. So it's not really cost effective. But there are some causes of chronic pancreatitis, like familial ones, which have a very high risk. So in selected causes, we do screening, not always. What are the options we have for pseudocysts? That's not really a part of this discussion. But the answer to that, which I will type in here, is that pseudocysts should be operated on if they are ripe. Sorry. Only if they are ripe for surgery, right? RIPE. If you think that a pseudocyst is going to rupture, or if it's getting infected, or if it's causing pressure effects, like if it's a lesser sac and it's so big that the person can't eat, or if it's eroding into a nearby organ, then only we would operate. We don't usually do anything to pseudocysts depending on size if none of those problems are there. Right? Incidental pseudocysts, again, the answer is if it's asymptomatic, we don't do anything. Can we differentiate clinically between chronic pancreatitis and chronic pancreatitis complicated by malignancy? That is a problem that all of us face on a daily basis. So the only thing we can go by is someone who anyway has pain and has loss of appetite and been having loss of weight but start their nutritional supplements and they're slowly gaining weight. Suddenly their pain is worsening and they're losing weight rapidly. Then we worry that they have a malignancy and then we do a CT. Do we give analgesics according to the pain ladder or multimodal analgesics? Usually it's the pain ladder, ascending. Anti-inflammatory drug therapies in severe chronic pancreatitis like steroids, actually no. There's no evidence steroids can cause pancreatitis also. CA19-9 in pancreatitis, it's usually done only if pancreatic carcinoma is suspected. Yes, right? Acute inflammation of the pancreas, obstruction of ducts can also raise CA19-9. So it's not a really reliable marker, right? Patients can get hypoglycemia. They in fact get a type of diabetes we call brittle diabetes, where they swing between hyper and hypo. So it's very difficult to control. Persistent nausea and vomiting is not actually a major concern. That's a good question. Now, acute pancreatitis is characterized by retching and vomiting all the time. No? Here, the bigger problem is pain. They don't get that much nausea and vomiting. Okay, Dr. Dixon, I think we have kind of gone about half an hour over. Sorry about taking so long.
Yeah, actually, it is, I know that it's very difficult situation. Anyway, that thank you very much, Dr. Buddhika, that giving us opportunity. I know it is very difficult to squeeze the big topic into 1.5 with that much of questions. Anyway, that is a very comprehensive discussion. I think this is a topic with a lot of confusion with the students. Therefore, that I think you got answers for. Now you understood very well. Therefore, that if you have more questions, I think you pose it. We try to sort it out later. Again, thank you very much. And there's another message you have to give. There's the next one. It will be on thyroid disorders. It will be not on tomorrow. It will be on Sunday at 8 p.m. by Dr. Diluka Pinto, surgeon, endocrine surgeon, Faculty of Medicine, Ragam. Then good night for all of you. Good night, Dr. Buddhika Dassanayake.
Thank you, Dr. Dixon. Good night.
Good night, sir. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.